talk. Next, we have Dr. Reesha KR, Senior Consultant from Little Flower Hospital, Angamali. She would be talking about the OCT biomarkers in posterior uveitis.
Thank you, Dr. Basil. I'll be talking about OCT in uveitis. As we all know, ancillary investigations are the backbone of uveitis workup, and OCT gives an optical biopsy of the posterior segment structures, and it helps in localization of the pathology by defining the extent, depth, and thickness of the inflammatory lesion. In intermediate and posterior uveitis, it helps in quantifying the macular edema, and also it has got high sensitivity for diagnosing CME in uveitis. And these are the three distinct OCT patterns in uveitic macular edema: diffuse, cystoid, and associated with serous retinal detachment. And we can also quantify the macular thickness so that we can monitor the response to treatment, and also recurrence following reducing dose of steroids. And these are the predictors of poor visual recovery. They are atrophy and disorganization of the inner retinal layers and disruption of the outer retinal layers and RPE. The presence of vitreomacular interfaces like ERM, vitreomacular traction, are identified by OCT and again causes treatment failure. And occasionally, posterior vitreous cells can be seen in OCT as hyperreflective vitreous particles. In the first picture, in intermediate uveitis with vitreous echoes, and in the second picture with the retinitis patch and vitreous cells. See, it's a case of retinitis. OCT shows inner layer hyperreflectivity with shadowing, and OCT also shows vitreous cells in this picture. And as the lesion heals, the hyperreflectivity reduces in size, and also vitreous cells disappear. It's a case of Behçet uveitis with whitish infiltrate in the posterior pole. OCT shows a hyperreflective focal retinal thickening with shadowing behind the lesion, and as the lesion heals, it forms a pseudofovea appearance due to slit-like retinal nerve fiber layer defect. And in acute retinal necrosis, OCT shows full thickness loss of retinal cells. And it's a case of syphilis causing outer retinal lesion. Outer retinal, these hyperreflective dots above the RPE is the hallmark of syphilitic lesion with fluid detachment. Here is a case of choroiditis showing elevated RPE with fluid detachment, and again contact sign is a marker for TB choroiditis in OCT. See, after the treatment, choroiditis lesion disappeared and RPE level became low. Again, in serpiginous choroiditis, active lesion shows a focal choroidal thickening with a hyperreflective deposits in the outer retina, and as the lesion heals, it becomes hypofluorescent and FFA in autofluorescent, and it causes thinning and loss of RPE, shows us hyperreflective thin choroid. Inflammatory CNVMs are better picked up by OCT or OCTA, and we can also determine the lesion activity to assess the response to treatment. In white dot syndromes, OCT shows photoreceptor layer loss and RPE disruption with focal choroidal thickening. In VKH and sympathetic ophthalmia, OCT shows fluid detachment with this characteristic septae appearance. And in this patient also had a CSR along with a serous PED. See, it's a case of sarcoidosis with multiple sarcoid granulomas, choroidal granulomas, showing this elevations of RPE localized with fluid detachment. This was a case of masquerade CA breast with choroidal metastasis. Again shows RPE, elevated RPE with the fluid detachment. No signs of any inflammation. EDI helps in identifying the response to treatment. The measure of enhanced depth imaging helps in response to treatment. The size, the choroidal thickness reduces in size as the lesion response. So OCT is very useful marker in diagnosing, ruling out certain differential diagnosis and monitoring inflammation during the follow-up of posterior uveitis.
Thank you, ma'am, for that case-based discussion on the OCT bio